So multiple nodules of different sizes are formed in both the lobes, also in the isthmus, which is firm, nodular, non-tender, and moves with deglutition. Now, recent increase in size. If there is a recent increase in size of the thyroid enlargement, it can be due to two things. It can be due to a malignant transformation of a pre-existing goiter, or it can be due to secondary hemorrhage inside the gland. A positive coccus test is due to compression over the trachea, where the patient usually shows signs of weakness of the trachea, known as your tracheomalacia, or a scabbard trachea, which usually happens in a long-standing multinodular goiter. The nodule, when calcified, it becomes harder, and then necrosis may soften the nodule. Now, the complications of a multinodular goiter is your secondary thyrotoxicosis. So, from a non-toxic goiter, it may transform into a secondary thyrotoxicosis in 30% of the case. It can even transform into carcinoma, usually the follicular variety, in 10% of the case. Or another complication can be due to hemorrhage inside a nodule, or a tracheal obstruction or calcification due to prolonged standing thyroid enlargement, or it may be a cosmetic problem for the patient. The investigations where we investigate a multinodular goiter is similar for any thyroid enlargement, but in addition to the thyroid profile, the ultrasonography, FNAC, X-ray neck, we usually send the patient to the ENT department for an indirect laryngoscopy. This is usually to examine the vocal cords of the patient prior to surgery. This is mainly for documentation and legal purpose, as even in individual with normal voice, one of the vocal cord may have been paralyzed by viral infection like mumps, or probably during childhood, and have been compensated over a period of many years. Then occasionally, like what I told you, in selected patients where it is indicated, you can go ahead with a radioisotope iodine scan, usually when you suspect malignancy. And then besides that, your routine blood investigation for the general well-being of the patient. The treatment is usually surgery, is the preferred treatment of choice. The reason for doing surgery in nodular goiter is that it is an irreversible stage. So it is not going to reverse back into a normal gland, but it is going to be enlarged, or maybe even get bigger over a period of time. So this is one of the indication of surgery. And the chances of complications like the one mentioned previously is high. So these are the two main indications for performing a surgery in a multinodular goiter patient. One is it is an irreversible stage, and number two, because of the associated complications. Now, when the entire gland is diseased, the operation of choice is the total thyroidectomy. That means the entire thyroid gland is removed. We're sparing the four parathyroid glands. Now, a subtotal thyroidectomy is done depending on the amount of gland involved, the amount of normal gland existing, and the location of the nodules. This is the commonly done procedure in case of a multinodular goiter. Now, what about a partial thyroidectomy or a Hartley Dunhill operation, which comprise removal of the isthmus plus one entire lateral lobe and the opposite side, subtotal or a partial? This is usually done. A partial thyroidectomy or a Hartley Dunhill operation is usually done depending again on the amount of the diseased gland, how much of a normal tissue is left behind. So, however, the partial thyroidectomy is not a well-approved procedure. Like what we said, the subtotal thyroidectomy is the most commonly performed or approved procedure. Now, post-operatively, irrespective of the type of surgery you choose, like how much of a thyroid gland you remove, Post-operatively, L-thyroxine is often given to this patient to prevent any fluctuation in the TSH level, and which may cause recurrent nodule formation. Remember, performing this surgery is not going to stop the pathophysiology of the disease. There's every chance that the normal tissue that are left behind will undergo the same pathophysiological stages again and become nodular. So prevention of multinodular goiter is possible by supplementing in the post-operative period with L-thyroxine at a dose of 0.1 to 0.2 milligram, and when the patient develops goiter in the puberty stage. Formation of a nodular goiter can be prevented by correcting the iodine deficiency by using iodine-rich diet. Now this is another very important and very commonly encountered thyroid condition, that is your solitary thyroid nodule. What do you mean by a solitary thyroid nodule? It is a single palpable nodule in a thyroid on clinical examination. I have told you previously that it is the single, that means the only nodule which is palpable on clinical examination. That is what we meant by solitary thyroid nodule. The only nodule which is palpable on clinical examination in an otherwise normal gland. That means the rest of the gland is completely normal. It is only that solitary nodule which is showing a pathological condition. The causes of a solitary thyroid nodule can be your thyroid adenomas, or it can be a follicular adenomas. The colloid form is the commonest, or it can be embryonal, fetal. Now another causes of solitary thyroid nodule is your Hürtel cell. Note that a papillary adenoma, earlier called, is actually a papillary carcinoma. So there is no condition anymore by the term papillary adenoma. We have only one term, that is your papillary carcinoma. Then you have another causes of solitary thyroid nodule is your papillary carcinoma of the thyroid. Let me emphasize again that we have a condition known as follicular adenoma and follicular carcinoma, but when it comes to papillary, there is no such thing like adenoma, it's just carcinoma of the thyroid. Then again, another causes of solitary thyroid nodule is, here only one nodule may be clinically palpable in an underlying multinodular goiter. This is another scenario where you will get a clinically solitary thyroid nodule. Actually, the entire gland is showing multinodular goiter, but the nodules are so small that only one is palpable on clinical examination. So this is another scenario where we get a solitary thyroid nodule. And another causes of solitary thyroid nodule is your thyroid cyst. The types, it again can be a toxic or a non-toxic or simple. Now based on the radioisotope study of these solitary nodules, it can be a hot nodule, a warm nodule, or a cold nodule. A hot nodule means it shows an autonomous toxic nodules. On its own, it's showing features of toxicity. Whereas a warm nodule, this is a normally functioning nodule, and a cold nodule is actually a non-functioning nodule, and it is a sign of malignancy until proven otherwise. Now the features of this solitary thyroid nodule is, like what the name suggests, it is a solitary nodule which is palpable in one or the other lobes of the thyroid. It is usually smooth and firm. Again, Lahaye's test, it does not show any other nodule in the posterior part of the gland. It is hot or warm while performing a 99M technetium scan, but cold in iodine 123 scan. It again, in extreme of ages, it usually suggests malignancy like the previous diffuse one, and a rapid enlargement, it can be due to malignancy or it can be due to hemorrhage inside the gland. These are the same thing. Now let us see what are the possible features of suspected malignancy in a solitary thyroid nodule. When do we suspect malignancy? Now, any nodule can be malignant, whether it is hard, firm, cystic, small, large, or asymptomatic. But remember the order. The harder it is, the more suggestive it is of malignancy. But you cannot exclude malignancy from a firm or a cystic. Like what I said in previously, that in few percentage of papillary carcinoma, it can be a cystic swelling as well. Then there will be rapid onset and rapid increase in size. Then another features of suspected malignancy is when there is hoarseness. Once hoarseness is there, it is a sign that the tumor has infiltrated into your recurrent laryngeal nerve. Or there can be dysphagia. That means the thyroid enlargement is huge enough to compress on the esophagus, which is situated posteriorly. Or it can give rise to stridor due to pressure on the vocal cords. And the next, patient can be due to compression on the trachea, patient can come with symptoms or complaint of dyspnea, that is your difficulty in breathing. Or on clinical examination of the solitary nodule, you will find that it is fixed to the surrounding structures. It is not mobile. You cannot move it sideways or up and down. Or on examination of the cervical lymph node, there will be palpable significant neck nodes. Now, when you get palpable significant neck nodes, again you should characterize the nature of the nodes, whether it is the palpable nodes, whether it is hard or firm or elastic, whether it is smooth or irregular, whether it is well defined, the margins, or it is ill defined. All these things again have to be put into perspective. Investigation is the same, and the treatment. Now, the treatment of a solitary thyroid nodule. The indications are, because a thyroid nodule, that means it is a solitary single nodule, usually it does not require operation if it is based on cosmetic reason only. This is the least indication. But if it shows signs of malignancy, definitely that will be the number one indication. Then if it shows features of follicular neoplasm, when we say neoplasm, remember follicular, it can be a follicular adenoma or a follicular carcinoma. In either ways, it will require surgery. Then we have the another indication is a toxic nodule in the young, or a nodules with obstruction, or a recurrent cystic nodule, or a complex cyst. That means it shows both cystic and solid components. And cosmetic reasons in very few cases, because usually it is not as big as that compared to your diffuse hyperplastic goiter.